I'm Dr. Rania Samir. I'm a professor of cardiology and a consultant of electrophysiology at Ain Shams University, and I'm going to talk to you about approaches to narrow complex tachycardia. And this is going to be our agenda for today. Before talking about narrow complex tachycardia, I would like to briefly review the normal conductive system of the heart. As we all know, the normal pacemaker of the heart is the SCA node, which is located at the high right atrium at the junction between the SVC and the right atrium. And it discharges at the regular resting rate of 60 to 90 beats per minute. And as the impulse comes out of the SCA node, it activates both atria, causing atrial depolarization, which presents itself on the surface ECG as P wave. After atrial activation, the impulse goes into the AV node, which is geographically situated at the lower interatrial septum, at a region known as the AV junction, close to the tricuspid annulus. And as the AV node has physiological properties of decremental conduction, so the impulse becomes delayed a bit inside the AV node and then conducted to the ventricular myocardium simultaneously and rapidly through a rapidly conducting conductive system known as the His-Purkinje system. That causes a rapid ventricular depolarization and a narrow QRS complex on the ECG taking about 100 milliseconds or less than this. And to obtain a narrow or a very rapid ventricular depolarization, the ventricle should be activated through this His-Purkinje system to produce a narrow QRS complex. Any activation of the ventricular myocardium any other way will take longer duration and it will produce a wider QRS on the ECG. Hence, that's why the narrow complex tachycardia is all the tachycardias that are characterized by a normal QRS duration and morphology, measuring less than 120 milliseconds. So, if we say this, so this type of to conclude, these types of tachycardias are the tachycardias that are originating from regions just above the His-Purkinje system, including the AV junction area and the atrial myocardium. Only a small, and they are collectively known as the supraventricular tachycardias. Only a small fraction of these arrhythmias, which are known as the narrow complex tachycardia, are ventricular tachycardia, and a special form of ventricular tachycardia known as the high septal or high septal fascicular ventricular tachycardia that are able to activate the His-Purkinje system and produce a very narrow QRS measuring less than 140 milliseconds. So when we talk about the differential diagnosis or the classification of narrow complex tachycardia, which are a group of tachycardias that are characterized by a normal morphology of QRS and duration of QRS less than 120 milliseconds, they can be classified based on the region from the site of origin of the arrhythmia or the regularity of the arrhythmia. And if we classify it according to the site of origin, they can be classified into atrial and AV junctional tachycardia, which are collectively known as supraventricular tachycardias, and they represent the majority or the majority of narrow complex tachycardia. Small fraction of these tachycardias, as we said before, they are the idiopathic ventricular tachycardia or high septal ventricular tachycardias that are characterized by a narrow complex or normal morphology of the QRS. The regular atrial arrhythmias included within the narrow complex tachycardia are the sinus arrhythmias, including physiological or inappropriate sinus tachycardia and sinus node reentry. Also, it includes focal atrial tachycardia or atrial flutter with fixed AV conduction. And in AV junctional arrhythmia, majority of them are reentrant arrhythmias, so all of them are regular arrhythmias, including atrioventricular reentrant. Atrioventricular nodal reentrant tachycardia, which is the AV nodal reentrant tachycardia, and junctional ectopic tachycardia and orthodromic tachycardia via an accessory pathway. The irregular arrhythmias or the irregular narrow complex tachycardias are all atrial. Most commonly is the atrial fibrillation and focal and multifocal atrial tachycardia and focal atrial tachycardia or atrial flutter with variable AV conduction. For the sake of time, we're not going to discuss during this lecture the idiopathic ventricular tachycardia or atrial fibrillation because they are going to be discussed in details in other lectures. Now we'll talk about the epidemiology of narrow-complex tachycardia. Most prominently is the narrow-complex supraventricular tachycardia, which represents the major chunk or the majority of narrow-complex tachycardia. It's a very common tachycardia. It's one of the most common tachycardias you can encounter in the ER or in the EP lab. And it has a high prevalence among the general population. It's women and older age adults or older age people, they are at greater risk in developing supraventricular tachycardia. In the cath lab, they are the most commonly encountered narrow-complex supraventricular tachycardias are atrial fibrillation in AV nodal reentrant tachycardias, followed by A.flutter and AV reentrant atrial tachycardia, AV reentrant tachycardia through an accessory pathway. Now we're going to discuss the most common narrow-complex supraventricular tachycardias with a specific diagnostic ECG morphology, starting with atrial arrhythmias. Most common of them, and they are commonly encountered in emergency room or in outpatient clinics, is the inappropriate sinus tachycardia. This is merely a sinus tachycardia characterized by a fast sinus rate more than 100 beats per minute at rest or minimal activity. And what characterizes inappropriate sinus tachycardia from appropriate sinus tachycardia? That it's out of proportion of physiological or pathological or even pharmacological stress. There is no underlying cause of this inappropriate sinus tachycardia. The majority of the patients complain of palpitation or tachycardia not related to any physiological or pathological stress. And it's usually persistent and it's commonly occur in young females. The exact mechanism of this tachycardia is actually unknown or poorly understood, but the majority of the theories depend on abnormality in the automaticity within the AC node. Either it's dysautonomia or hyperactivity within the AC node or neurohormonal dysregulation. And since the mechanism relies mainly on abnormality in the automaticity with the AC node, so it has a characteristic feature, this kind of sinus tachycardia, that it has a warm-up phenomenon and warm-down phenomenon. What does it mean? That these types of tachycardia has a gradual increase in the rate and a gradual drop in the rate, and the patient can significantly or can specifically, if asked, can determine this property of the tachycardia. So it's like any other sinus tachycardia. The physiological sinus tachycardia presents itself in the same way. So how can you differentiate between appropriate and inappropriate sinus tachycardia is the underlying cause. Appropriate sinus tachycardia, if you examine the patient or you have good history from the patient, you'll find an underlying cause or a causative mechanism causing this tachycardia, whether it's anemia, fever, physiological stress, or emotional stress. But inappropriate sinus tachycardia, there is no underlying cause. Both types of tachycardia, the ECG diagnosis, which is the landmark or the key diagnostic feature in or investigation for diagnosis of arrhythmia in general, they have the same ECG morphology. You have tachycardic rhythm more than 100 beats per minute with a normal morphology of QRS and narrow QRS measuring less than 120 milliseconds. You have significant apparent P waves in the ECG, and these P waves have a sinus morphology, sinus rhythm morphology, being positive in lead 1 and lead 2 and AVF, and negative in AVR and biphasic P waves in V1. Also, one of the important diagnostic investigations of inappropriate sinus tachycardia is 24-hour Holter monitoring, which will show a mean heart rate more than 90 beats per minute and an exaggerated heart rate response more than 100 beats per minute during waking hours. So most of the time the patient has a tachycardic rhythm that is unexplained. The mean heart rate is around 90 beats per minute or more, and any minimal activity will be manifested by exaggerated heart rate response more than 100 beats per minute. It's very important to know the differential diagnosis of inappropriate sinus tachycardia. The most important differential diagnosis is appropriate sinus tachycardia that has a real cause of it, whether it's physiological or pathological due to anemia, thyrotoxicosis, or fever, or sinus node re-entry. Sinus node reentry is the patient will come and complain from inappropriate of a sinus tachycardia that is not explained. The difference between it and the inappropriate sinus tachycardia, that inappropriate sinus tachycardia is mostly due to abnormal automaticity, so you will have a warm up and warm down phenomenon, while sinus node reentry, there is it's a re-entry circuit within the SA node, so it has a paroxysmal nature. It's abrupt initiation and termination of the tachycardia. Also, one of the most important differential diagnoses of inappropriate sinus tachycardia is postural orthostatic tachycardia. It's one type of sinus tachycardia or sinus tachycardia caused by orthostatic stress where there is an increase in the sinus rate, more than 30 beats per minute or more than 40 beats per minute during adolescence when the patient changed position from supine position to standing position after 30 seconds. The second important atrial arrhythmia that we have to know about is the focal atrial tachycardia, and it's by definition, it's an organized atrial rhythm with a heart rate more than 100 beats per minute initiated from a discrete focus that arises either in the right atrium or the left atrium, and it spreads and the activation spreads over both atria in a centrifugal pattern. The mechanism of this tachycardia is either enhanced automaticity or triggered activity, and dependent on the mechanism, the tachycardia, focal atrial tachycardia presents itself. When it's enhanced automaticity, usually it's incessant and persistent tachycardia, and is difficult to be induced by programmed electrical stimulation in EP lab or during an EP study, while in triggered activity, if it's due to triggered activity, it has a more paroxysmal nature, so abrupt termination and abrupt initiation. This type of tachycardia, the focal atrial tachycardia, has a low prevalence in general population. It's not very common arrhythmia. It's only common in pediatric age group, and most commonly when it comes in pediatric age groups, it's incessant and it might precipitate for tachycardia-induced cardiomyopathy. And when tachycardia-induced cardiomyopathy happens, this prompts an acute intervention or acute management that will terminate this tachycardia at once. The ECG diagnostic features of focal atrial tachycardia that it has a regular atrial rate ranging from 100 beats per minute to 250 beats per minute. And it's characterized by discrete monomorphic abnormal P waves, different from the sinus P waves. And it has a stable cycle length. And the regularity or the AV conduction depends on the atrial rate or and the AV nodal conduction. Sometimes when the atrial tachycardia is slow enough, it can be conducted or presented in pediatric age group. It can be conducted with one-to-one conduction with very fast rate or very slow rate. With one-to-one AV conduction, but sometimes when the atrial rate is so fast, the AV conduction cannot follow, so atrial tachycardia can be presented with 2-to-1 conduction, 3-to-1 conduction, or even variable conduction. And when it's presented with variable conduction, due to the variable AV conduction, spontaneous or by the effect of drugs, it presents itself with an irregular ventricular rate. Also, the polarity of the P wave can define the origin, the chamber of origin of the atrial tachycardia. A negative P wave in lead 1 and AVL and a predominantly positive P wave in V1 suggests a left atrial origin, and the reverse suggests a right atrial origin. Whenever you have a predominantly positive P wave in lead 1 and AVL and negative in V1, it suggests a right atrial origin. The third atrial arrhythmia that is important and we have to know about its mechanism and ECG diagnosis is the atrial flutter. It's a macro-reentrant atrial arrhythmia that is characterized by a regular circular activation around a certain anatomical or functional obstacle. Whether sometimes it's not a very common atrial arrhythmia. It's commonly presented in patients with structural heart disease. And re-entry circuit is the most common type of it is the cavotricuspid-dependent atrial flutter, which are known as the typical atrial flutter, where the re-entry circuit circulates around the tricuspid annulus in the right atrium. Less commonly, there's atypical forms of atrial flutter, which is either right atrial flutters or left atrial flutters, which the entry circuit circulates around certain anatomical obstacles in the right atrium and left atrium, and these are less common than the most typical atrial flutter that we are acquainted with. And as we said, this is a reentrant tachycardia, where the activation moves in a circular fashion around a well-circumscribed, a well-defined path over and over again. That's why this type of tachycardia is a highly regular tachycardia as far as the atrial rate. The ECG criteria of typical atrial flutter or cavotricuspidismus flutter is characterized by a regular atrial rate measuring from 250 beats per minute to 33 beats per minute with a uniform flutter waves with characteristic sawtooth appearance, as we can see here in this ECG of a patient with a counterclockwise atrial flutter. We can see a uniform morphology of the flutter waves with characteristic sawtooth appearance, and there is no isoelectric interval between the P wave, but this is not but the presence of isoelectric interval doesn't exclude the presence of atrial flutter. You can see it in atypical atrial flutter. The ventricular rate depends on the condition of the AV conduction. Most commonly in atrial flutter, the AV conduction is 2:1 or 3:1, and it will present with an ECG with regular rate, and sometimes it's variable AV conduction and will present with an irregular heart rate. Uncommonly, the atrial flutter can present with a 1:1 AV conduction, and this condition, it's very difficult to discern or to see the flutter waves with a very rapid rate or ventricular rate of 300 beats per minute. But whenever you have an ECG of narrow complex tachycardia with a heart rate reaching up 300 beats per minute, you have to suspect atrial flutter with 1:1 AV conduction. We'll move secondly to the AV junctional arrhythmias, which are the most common type of narrow complex supraventricular tachycardias. One of the most AV junctional arrhythmia that we encounter in our daily practice is AV nodal reentrant tachycardia. It's a micro-reentrant tachycardia that occurs within the AV node. It's called micro-reentry because the reentry circuit is confined to a very small space which is within the AV node. And as we all know that any reentry circuit needs a well-defined circular path or reentry circuit that the activation moves in a circular fashion on and on again, and it needs two pathways, one slow pathway and one fast pathway to allow the initiation and maintenance of this tachycardia. In patients with dual AV nodal physiology within the AV node, you'll find two pathways, a slow pathway and a fast pathway. And in normal situation, during sinus rhythm, the sinus beat comes to the AV node and finds the fast pathway that conducts very rapidly and another slow pathway that conducts slowly. So the impulse goes down in both pathways, and since the fast pathway conducts fast, so it conducts fast to the ventricle, causing activation of the ventricle and QRS, and a short or a normal PR interval, and the impulse that goes into the slow pathway gets blocked. This is a normal situation. But in AV nodal reentrant, when typical AV nodal reentrant tachycardia happens and atrial extrasystole happens, it comes and finds one of the pathways is refractory. In typical AV nodal reentrant tachycardia, the fast pathway has fast conduction and long effective refractory period, while the slow pathway conducts slowly but has a short effective refractory period. So when the atrial premature comes, it finds the fast pathway blocked or refractory, so it's forced to go down the slow pathway and move slowly inside the slow pathway till it conducts to the ventricle, so it will produce a very long PR interval. Then the impulse after activation of the ventricle will go up again through the fast pathway, which now is recovered from refractoriness and ready to conduct retrogradely, fastly into the atrium, causing a retrograde conduction into the atrium and production of a retrograde P wave. And here, since it conducts so rapidly, so the RP interval is short. And if this phenomenon repeats itself again and again and again, we'll be presented with what is called typical AV nodal reentrant tachycardia with short RP interval, and it goes into the under the big definition of short RP tachycardia. We have another type of AV nodal reentrant tachycardia, which is the atypical form of AV nodal reentrant tachycardia, or fast slow tachycardia, and it's less common. It represents less than 10% of all the AV nodal reentrant tachycardia we're going to see in the emergency room. And in this situation, the situation is reversed. The refractory period of the fast pathway is short, while in the slow pathway, its refractory period is long. So when the atrial extra stimulus comes, it finds the fast pathway running, and it conducts rapidly through the fast pathway to the ventricle, producing a normal PR interval, and activates the ventricle. And then when it moves up again, finds the slow pathway ready, and it's out of refractoriness, and it conducts slowly retrogradely into the atrium, producing a retrograde P wave that is far away from the previous R wave, producing a long RB interval. And if this process repeats itself again and again, will be presented by a tachycardia, a long RP tachycardia, or a typical form of AV nodal reentrant tachycardia, which is not common. This AV nodal reentrant tachycardia is one of the most common arrhythmias you can encounter in the emergency room, and it's very common in men and females more than males. The ECG of the typical AV nodal reentrant tachycardia, as I talked before about its mechanism, it's characterized by a narrow complex supraventricular tachycardia, unless there is a rate-dependent bundle branch block. It's very regular because it's a reentrant arrhythmia. The heart rate usually ranges from 150 to 250 beats per minute, and it has a short RP interval, so it's called a short RP tachycardia. Usually, the retrograde P waves in the majority of cases is not visible and buried within the QRS complex, but in 1/3 of the cases it can be visible, and you can see a short RP interval with a retrograde P wave presenting itself as an R dash in lead V1, as we can see in this ECG, in lead V1, and pseudo R in AVR, and pseudo S in inferior leads. But when you have a typical AV nodal reentrant tachycardia, which is a fast, slow AV nodal reentrant tachycardia, it's also a narrow complex supraventricular tachycardia. And I said before, it's less common. It represents only 10% of all the AV nodal reentrant tachycardia cases. Also, it's extremely regular because it's a reentrant arrhythmia. But here, as we said, the antegrade limb is the fast pathway and the retrograde limb is the slow pathway. That's why the RP interval is long. So the retrograde P wave is mostly visible, and the RP interval is very long, is longer than the PR interval. So it's a long RP tachycardia, and it goes into the differential diagnosis of the majority of long RP tachycardia. Then we'll move to the second most important AV junctional arrhythmia, and that is commonly encountered in the emergency room, is orthodromic tachycardia. This is one of the arrhythmias that is caused by an accessory pathway. So what is an accessory pathway? Accessory pathway is an anomalous muscular band that connects the atrium to the ventricle, bypassing the AV node. And in the majority of the accessory pathways, or more than 90% of them, they conduct antegrade, both in the antegrade direction and the retrograde direction. And they lack the property of the AV node of decremental conduction. The conduction across the accessory pathway is so fast, there's no decremental conduction either way. There's another portion of the accessory pathways or other forms of accessory pathways known as the concealed accessory pathways, and they represent a small fraction of accessory pathways, less than 50% of them, and they are different from regular pathways that they conduct only in the retrograde direction. There is no conduction in the antegrade direction. So what's the difference between both pathways? The regular pathways, the regular accessory pathway, as I said before, it conducts both antegradely and retrogradely. So during sinus rhythm, when the impulse comes out of the SA node, it moves in two directions. One towards the AV node, which is the normal pathway, and another direction towards the accessory pathway, pathway and conducts so rapidly into the ventricle. So the activation of the ventricle happens through the AV node and the accessory pathway, causing certain changes in the ECG, as we can see here on the left side panel, known as the manifest pre-excitation. As the ventricular activation happens through fusion between the AV node and the accessory pathway that doesn't have decremental conduction, so it shortens the duration of PR interval, causing a characteristic short PR interval on the ECG, and a widened QRS complex and a slur on the upstroke and downstroke of the QRS known as the delta wave. These features are characteristic or pathognomonic of a presence of an accessory pathway. We call it manifest pre-excitation. And when this patient complains of tachycardia or experiences tachycardia, this becomes a Wolff-Parkinson-White syndrome. So how to differentiate by ECG between regular accessory pathway and concealed accessory pathway? A regular accessory pathway manifests itself on the ECG by the manifestations of manifest pre-excitation, while in concealed accessory pathway, since it conducts only in the retrograde direction, so in antegrade conduction is solely done through the AV node or carried out through the AV node, producing a completely normal resting ECG, since the accessory pathway only functions in retrograde direction. So what is orthodromic tachycardia? As I said before, orthodromic tachycardia is one of the tachycardias caused by an accessory pathway and is the most common form of arrhythmias caused by accessory pathway. It's a macro-reentrant tachycardia, whereas the entry goes around the area of the AV junction. In orthodromic tachycardia, the antegrade limb of the tachycardia is the AV node. So the conduction goes from the atrium to the ventricle through the AV node. And then the retrograde limb of the tachycardia is the accessory pathway. After it goes down through the AV node and activates the ventricle, it retrogradely activates or conducts through the accessory pathway up and activates the atrium. And the re-entry circuit moves in a circular fashion in this direction. So since the antegrade limb is through the AV node, this produces a normal morphology, a normal duration of the QRS, because the antegrade conduction is through the AV node, which is a normal pathway of the normal conductive pathway of the heart. And then retrograde limb is the accessory pathway, so the impulse will conduct from the ventricle to the atrium, activating the atrium retrogradely through a rapidly conducting accessory pathway, causing retrograde activation of the atrium and a short RP tachycardia. As I said before, this tachycardia represents more than 90% of the AV reentrant tachycardia and represents 20 to 30% of all sustained supraventricular tachycardia. It's a very regular tachycardia because it's a reentrant tachycardia ranging in rate from 150 to 220 beats per minute. And it's a short RP tachycardia, and usually it's associated with an ST segment depression. The last AV junctional tachycardia we are going to talk about is the junctional ectopic tachycardia. It's a very uncommon and very rare arrhythmia. We only see it in neonatal or pediatric age group. It's very rare in adults, and it's caused by abnormal automaticity of the AV node or the proximal His bundle. The ECG diagnosis of it, it's of course the ECG is a narrow complex tachycardia or supraventricular tachycardia, and it's very regular. It's a short RP tachycardia. If there is a retrograde P wave, it's a short RP tachycardia, and sometimes there is AV dissociation. It's very uncommon tachycardia. You will see it, you will unlikely see this ECG in your normal practice, or you can see it once or twice. Now we'll move to the clinical presentation of narrow complex tachycardia. As I said before, it's a very common tachycardia. You can encounter it every day in your emergency room or in your daily practice. And it's usually symptomatic. And the most prominent presentation of this tachycardia, the most prominent symptom is palpitation. The patient will come complaining from palpitations, sometimes complain of palpitations alone or associated with other symptoms. Other symptoms like low cardiac output symptoms, including dizziness, ranging from dizziness, fainting, or up to syncope, or shortness of breath, dyspnea, or chest discomfort. Taking history of the patient with palpitation is very important to reach a diagnosis, the type of the arrhythmia and the mechanism, and also the mechanism of the arrhythmia. Like duration of symptoms, our age of onset of symptoms. If the patient is about is 35 or 23 years old and complaining of recurrent attacks of palpitation, and his history goes back since he was 9 or 10, so it gives you an idea that this is most probably an orthodromic or an AV reentrant tachycardia caused by an accessory pathway, because it has a very long duration starting from pediatric age group, most probably. And also the presence of symptoms of heart failure can indicate the occurrence of tachycardia-induced cardiomyopathy and prompts you to act rapidly and manage this tachycardia rapidly. Also, the sudden onset and termination of the tachycardia or the paroxysmal nature of the tachycardia can give you a clue that it might be a reentrant tachycardia or caused by triggered activity. Also, the rhythm regularity can give you a clue about the type of tachycardia. If it's completely irregular, so you might think it's an atrial fibrillation or multifocal atrial tachycardia. If it's regular and paroxysmal, so we will move towards the reentrant tachycardias or focal atrial tachycardias. So during initial evaluation of any patient with arrhythmia, you have to have an ECG. You have to have an idea about the resting ECG or the ECG of documented tachycardia. They are the cornerstone in the evaluation of these patients, and you can reach a diagnosis using only these tools. So the resting ECG can show manifestations of manifest pre-excitation. So when a patient comes complaining of palpitation and has a resting ECG of manifest pre-excitation, so the tachycardia he's complaining of is most probably AV reentrant tachycardia. An ECG of documented tachycardia can be a spot diagnosis. You can diagnose the arrhythmia from it. Also, another tool in evaluation of the patient is history, and its history, and its history. History taken is very important in arrhythmia patient. You have to know the duration of the palpitation, the age of onset of the symptoms, the duration and frequency of the palpitation, the regularity of the rhythm, what precipitates it, what stops it, how it terminates, how it initiates, the pattern. Is there a warm-up phenomenon, warm-down phenomenon? Is it a sudden or paroxysmal tachycardia? All of this will give you a clue about the type of arrhythmia, added to it the use of the ECG. If there is no ECG of documented tachycardia and the resting ECG is not giving you any clues, you can use other investigations, including 24 hours Holter monitoring that can record arrhythmias that can happen to the patient, provided that this arrhythmias are very frequent and happens daily. If it's infrequent, so it's of no use, you can use a longer monitoring technique like transtelephonic monitoring or implantable or even implantable loop recorders. Also, lab investigations are ancillary or helpful, but it doesn't help so much in the diagnosis. Also, transthoracic echo is very important in evaluation of patients of arrhythmia to know if there is a tachycardia-induced cardiomyopathy or a patient has a structural heart disease, because some of the arrhythmias are associated with structural heart disease like atrial flutter. So, how to evaluate an ECG of documented tachycardia? You have to evaluate it systematically. First, you have to know if it's tachycardic rhythm or not. You have to measure the heart rate. If it's more than 100 beats per minute, so it's a tachyarrhythmia. And then you look into the QRS. If it's measured less than 120 milliseconds, so it's a narrow complex tachycardia. After that, you look at the regularity of the tachycardia. If it's regular, you look for P waves. If there is P waves, then you measure the relation between the ventricular rate and the atrial rate. If the atrial rate is more than or greater than the ventricular rate, so it's most probably atrial flutter or focal atrial tachycardia with variable AV conduction, or rarely it can happen in AV nodal reentrant tachycardia, but it's a very rare situation. But if the ventricular rate is greater than the atrial rate, then it might be the less common or the very less common narrow complex tachycardia, which is the high septal or high septal fascicular ventricular tachycardia, or it can be the junctional ectopic tachycardia, and in very rare situation, AV nodal reentrant tachycardia. If the atrial rate exactly equals the ventricular rate, we have to look into the RP interval. If it's a short RP interval, so it's most probably typical AV nodal reentrant tachycardia. If it's a short RP interval and less than 90 milliseconds, so it's most probably typical atrial flutter. This is the most likely diagnosis, or a focal atrial tachycardia, or junctional ectopic tachycardia, and rarely AV reentrant tachycardia. But if it's a short RP interval, more than 90 milliseconds, so it's most probably AV reentrant tachycardia or an accessory pathway tachycardia. Less likely it's an AV nodal reentrant tachycardia or focal atrial tachycardia. If it's a long RP, on a pure long RP tachycardia, so the most probable diagnosis is focal atrial tachycardia, and it might be AV reentrant or atypical AV nodal reentrant tachycardia. So, but what if the rhythm is irregular? If it's irregular, so the most likely diagnosis is either atrial fibrillation, so it's most probably atrial. It's atrial fibrillation or focal atrial tachycardia or atrial flutter with variable AV conduction. Also, when you're evaluating patients with narrow complex tachycardia, and the ECG of documented tachycardia is very rapid and you cannot reach a diagnosis, a conclusive diagnosis, some intravenous drugs like adenosine can help you reach a diagnosis. Adenosine is a very important drug in the diagnosis and management of narrow complex supraventricular tachycardia. It's an endogenous purine derivative that has an important effect on the SCA node and the AV node. It slows the conduction within the SCA node and AV node, reaching up to a transient AV block. The most important thing about this drug that it doesn't affect the blood pressure, and the plasma half-life is very short, so it has a short duration of action, and then its effect disappears. So it's a very valuable drug for diagnosis of the type of the tachycardia when you cannot reach it with using the ECG of documented tachycardia. And depending on the response to the adenosine, it can give you a clue about the mechanism or the type of the tachycardia. When you give intravenous adenosine and you have no effect, you have to suspect it's a ventricular tachycardia, because adenosine usually or mostly doesn't have an effect on the ventricular myocardium or the accessory pathway. So if there is no effect, so you have to suspect that you have a high septal ventricular tachycardia or fascicular tachycardia, or you're not given an adequate dose. If the ECG shows gradual slowing, then reacceleration, so this gives an idea that this underlying mechanism is an autonomic mechanism. So you have to think about sinus tachycardia, automatic focal atrial tachycardia, or junctional ectopic atrial tachycardia, because all of these tachycardias, the underlying mechanism is related to enhanced automaticity. If there is sudden termination, you have to think about it's either reentry or triggered activity. So it's either AV nodal reentrant tachycardia or AV reentrant tachycardia, sinus node reentry, or triggered focal atrial tachycardia. But if there is persistent of tachycardia, if there is a persistent of atrial tachycardia, but adenosine can cause a transient AV block that can elicit these P waves to see them and to elicit that is atrial arrhythmia, it can help you in diagnosing focal atrial tachycardia or atrial flutter. Now we'll move to the second part of the lecture, which is acute management of narrow complex tachycardia. Now we'll talk about the acute management of narrow complex tachycardia when you cannot reach a diagnosis based on the ECG during tachycardia. You have an ECG and you cannot for sure say what kind of tachycardia this is. This is a narrow complex tachycardia, but I don't know if it's an atrial fibrillation or an atrial or a focal atrial tachycardia or AV reentrant tachycardia. So we will treat it as a narrow complex tachycardia in the emergency room. And the treatment depends on the regularity of the tachycardia. If the tachycardia is regular, so you have to look for hemodynamic stability. If the patient is hemodynamically unstable, you go for synchronized DC shock. You don't wait, because now you have a risk for the life of the patient. But if the patient is hemodynamically stable, you start with vagal maneuvers in the form of Valsalva maneuver or carotid sinus massage. These are physiological maneuvers that the patient even can use before going to the hospital. They have a wide range of effectiveness. Its effectiveness reaches to up to 50%, but in the majority of cases, it doesn't succeed in termination of the tachycardia. If it turns out to be ineffective, you can use intravenous adenosine, which is the class 1 drug for termination of regular narrow complex tachycardia. You start with a dose of 6 milligram, titrate the dose in an incremental doses up to 18 milligram. If it turns out to be ineffective, you can go to the second line drugs which are calcium channel blockers and beta blockers. And if it didn't succeed, you move to, you can give a synchronized DC shock. Then we'll move to treatment of a specific arrhythmias. If you reach a diagnosis, depending on the ECG of documented tachycardia, and you reach diagnosis, so you can treat this specific tachycardia accordingly. We'll start with sinus tachycardia, whether it's appropriate or inappropriate. If it's the sinus tachycardia is appropriate, so you start treatment with treating the underlying cause. If it's fever, you treat the fever. If it's anemia, you treat the anemia. But if it's inappropriate arrhythmias or inappropriate sinus tachycardia, you start with drugs. One of these drugs is ivepradine, which is a very effective drug, a very good drug, and it acts selectively on the IF current or the pacemaker current within the SCA node, slowing the conduction within the SCA node. And you can use it alone or in combination with beta blockers if it's not effective. And you can use beta blockers alone as a single agent. But if it's failed or the patient is still symptomatic with recurrent arrhythmia, you can use combination of both drugs. But if the patient turns out to have a sinus node re-entry, so it's better to go for catheter ablation, because catheter ablation in sinus node re-entry has a favorable effect or favorable results compared to drugs. But it has no value in inappropriate sinus tachycardia. So unfortunately, inappropriate sinus tachycardia, the only treatment for it is medical treatment. Catheter ablation has very disappointing and very unfavorable results. Focal atrial tachycardia, acute management of focal atrial tachycardia also depends on the hemodynamic status of the patient. If the patient is hemodynamically unstable, we go for synchronized cardioversion. But if the patient is hemodynamically stable, we start with adenosine. We said this is the most important drug in treatment of narrow-complex supraventricular tachycardia. And it can successfully terminate focal atrial tachycardia caused by triggered activity. If it turns out to be ineffective, we move to the second line treatment, drugs which are calcium channel blockers like verapamil and diltiazem, or beta blockers or intravenous beta blockers. And if they turned out to be ineffective, the third line treatment, they are not favorable and they are not recommended, highly recommended, but you can use them, like intravenous ibutolide or class 1C drugs or even amiodarone. And if they turned out to be ineffective, you go for synchronized DC shock. There's an important note we have to know, that even DC shock can be ineffective if it's an automatic focal atrial tachycardia. It can terminate the tachycardia for a few seconds or a few minutes, and then it can recur again. And in this instant, the only treatment of choice of focal atrial tachycardia, if it's recurrent or even insistent, especially if it's causing tachycardia-induced cardiomyopathy, is catheter ablation. It has a very high success rate in ablating focal atrial tachycardia, whether it's caused by triggered activity or especially if it's enhanced automaticity, because most of drugs, even DC shock, will be ineffective in treating automatic focal atrial tachycardia, and the only solution is going to be catheter ablation. But if it's not recurrent and not insistent, and drug therapy is desirable for the patient, so you might try beta blockers or calcium channel blockers or even class 1C drugs. It can be effective. Amiodarone is only preserved for young or pediatric patients or patients with LV dysfunction. Of course, long-term efficacy of this drug is limited by its side effects. Here in these graphs, we can see that catheter ablation of focal atrial tachycardia, as I said before, the success rate of focal atrial tachycardia during conventional EP techniques or even CAR2, 3D electroanatomical mapping, has a very high success rate, reaching up to 100 beats per minute with a very low complication rate. And whether it comes out, whether it's originating from the right atrium or the left atrium, it has very long-term success rates. As regards acute management of atrial flutter, if you have a patient with atrial flutter, macro-reentrant atrial tachycardia, whether it's a tricuspid dependent or atypical atrial flutter, also acute management depends on this hemodynamic stability of the patient. If the patient is hemodynamically unstable, so you go directly into synchronized DC shock, the patient has to go back to sinus rhythm as soon as possible. But if the patient is hemodynamically stable, so if the patient is hemodynamically stable and has a very high ventricular rate, we have to resort to rate control first using beta blockers or calcium channel blockers, and then we attain the rhythm control strategy, either using electrical cardioversion, which is the most effective form of therapy for reaching rhythm control, or cardioversion in atrial flutter patients. You can use, if electrical cardioversion is not desirable or not feasible, and if the patient has a pacemaker in or ICD in, you can use high rate atrial pacing, or even a shock from the device can cardiovert the patient. But if the patient doesn't have a pacemaker and electrical cardioversion is not feasible or is not desirable, you can use drugs, but it's less effective than cardioversion, like intravenous ibutolide or intravenous or oral dufetilide in hospital. Class 1A and Class 1C have little effect, and if you resort to using Class 1C in atrial flutter, you have to use it in conjunction with beta blockers, because it has the risk of slowing down the flutter rate and causing one-to-one AV conduction that might cause ventricular fibrillation. How about the chronic therapy for atrial flutter? In atrial flutter, if the patient has symptomatic and recurrent atrial flutter, so the most effective therapy and the first line therapy is catheter ablation. It has a very high success rate, long-term success rate. But if the tachycardia is infrequent or non-recurrent and drug therapy is desirable, you can use beta blockers or calcium channel blockers for rate control, or even you can use amiodarone, especially if the patient has LV dysfunction. But the best treatment of atrial flutter or for long-term rhythm control is catheter ablation. No drug is effective in long-term rhythm control of atrial flutter. As regards the anticoagulation, it's well known recently that atrial flutter carries a high risk of high thromboembolic risk, not as high as atrial fibrillation, but still it's reported. So in patients with atrial flutter, especially if they had a complaint of atrial fibrillation or were presented with atrial fibrillation, they should be anticoagulated. But if patient has only atrial flutter, anticoagulation can be considered in his future management. As I said before, the success rate of atrial flutter ablation, whether it's a cavo-tricuspid-dependent atrial flutter or even atypical atrial flutter, is very high, reaching up to 95% in cavo-tricuspid-dependent atrial flutter with a recurrence rate of less than 10%. As we can see in this upper graph, we ablate at the critical isthmus of the cavo-tricuspid isthmus or typical atrial flutter, which is situated at the floor of the right atrium. It's a triangular in shape, and the critical isthmus starts from the tricuspid annulus anteriorly back to the inferior vena cava. And if we create a complete line of block across this area, we can successfully terminate this atrial flutter without recurrence. As far as acute management of AV nodal reentrant tachycardia, also it depends on the hemodynamic stability of the patient. If the patient is hemodynamically unstable, we go for synchronized cardioversion. You have to cardiovert this patient as quickly as possible and regain sinus rhythm as quickly as possible for the risk of mortality. But if the patient is hemodynamically stable, you start with vagal maneuvers, and even vagal maneuvers, the patient can try it at home if he's hemodynamically stable before reaching the hospital. And as I said before, the vagal maneuvers are not very successful. We don't have to rely on them. Then we move to the first line therapy or drug, or the drug of choice in treatment of narrow complex supraventricular tachycardias, intravenous adenosine. You can use it in incremental doses starting from 6 milligram to up to 18 milligram intravenous with a success. It has a high success rate in terminating AV junctional arrhythmias, more than 90%. If it turned out to be ineffective, you can move to the second line drugs, which are calcium channel blockers or beta blockers. As far as long-term management of AV nodal reentrant tachycardia, the treatment of choice for patients with recurrent symptomatic AV nodal reentrant is catheter ablation with slow pathway ablation. Slow pathway ablation is a very easy technique, and the slow pathway is usually situated at the base of the Koch triangle, which is an imaginary triangle, as we can see here in this upper diagram. It's situated between the septal leaflet of the Turcos valve anteriorly and an imaginary line known as the Eustachian or the tendon of Tudor, which is the extension of the anterior extension of the Eustachian ridge. The apex of this triangle is the AV node at the base of the coronary sinus ostium, and we ablate the slow pathway near the coronary sinus ostium, or the base of this triangle. The success rate of this procedure is 97%, the recurrence rate is less than 4%, and the incidence of AV block is very low, with a less incidence with cryoablation. When it comes to AV reentrant tachycardia caused by an accessory pathway, the acute therapy of it also depends on the hemodynamic stability and the management. And if we look to this diagram, the management of AV reentrant tachycardia is exactly, the acute management of AV reentrant tachycardia is the same as AV nodal reentrant tachycardia if it has a narrow complex. As if the patient is hemodynamically stable, we start with vagal maneuvers. If it didn't work, and it's an orthodromic tachycardia, we give intravenous adenosine. It's our first choice drug. If it failed, we go to the second line drugs, which are calcium channel blockers and beta blockers. And if they fail, we go directly into cardioversion. And in case of patients with recurrent and highly symptomatic orthodromic tachycardia, or if patient had hemodynamic instability, one of the episodes you have to go directly into catheter ablation. Drug therapy is only preserved if the patient has very infrequent or less symptomatic arrhythmias, using calcium channel blockers or beta blockers or even class 1C drugs. But the treatment of choice for recurrent and symptomatic orthodromic tachycardia is catheter ablation. It also has a very high success rate, reaching 95% with a very low complication rate, and you can ablate it conventionally from the right side if the accessory pathway located around the tricuspid annulus, or from the left side through transeptal approach or retrograde approach if it's located around the mitral annulus. The take-home message of this lecture is supraventricular tachycardia is one of the common arrhythmias encountered in the emergency room and the EP lab. Vagal maneuvers and adenosines are the treatments of choice of acute therapy of supraventricular tachycardia and may also provide important diagnostic information. Catheter ablation is the treatment of choice for all reentrant and most focal arrhythmias, especially if they are recurrent and highly symptomatic. Sotalol is not recommended in the treatment of supraventricular tachycardia. You shouldn't use it. Class 1C drugs are not recommended in patients with left bundle or with ischemic or structural heart disease. Thank you.